let's move on from this. So the younger patient, triplet therapy, most people aiming for complete remission, but most people still using transplant to get there. A little bit more investigational at Sloan Kettering. Everybody's using maintenance, validated by a meta-analysis, and for high-risk patients, people are adding proteasome inhibitors as well. Let's just turn our attention now to the more frail elderly patient, and tell me what you're doing there, Ola. What do you do with somebody who's 84 and comes in, well, that's maybe too old, 82, comes in with myeloma? You're not going to transplant them, obviously.
Yeah, so we, as a default, probably would have lenalidomide dexamethasone as our standard therapy. That could be instances where we could do bortezomib dexamethasone. If the patient tolerates 3 drugs, probably a lighter version of RVD would be our default. For example, we give lenalidomide 15 milligrams or something like that. And depending on how frail the patient is, maybe we would scale back to maybe once a week or a lower dose of bortezomib twice a week.
I must say that's sort of been my approach recently, is VRD light, as we call it. Any deviation from that? What are other people using Upfront?
One important comment, again, to risk. In the elderly, they're highly enriched for hyperdiploid trisomies, low rate of high-risk disease. So that's the one thing I would diverge. That's the only patient population where I would consider a doublet, an RD in a frail elderly person who has hyperdiploid disease and not high-risk markers. You can always add something else. I know Antonio has rightfully stated that we can't sometimes catch up, but for that patient population, it's a great balance between convenience, efficacy, and tolerability.
Yesterday there were some, thank you, Rafael, there were some presentations on new combinations in the frontline setting. Bill, you were the moderator of the discussion of that, and one particular, if I recall right, there were a presentation on ixazomib in the frontline setting. What were your thoughts on that?
So there was a presentation of a phase 1/2 study of ixazomib, which is the oral proteasome inhibitor. It is a boronic-based proteasome inhibitor, similar to bortezomib, but it's given orally in combination with cyclophosphamide and dexamethasone. All this is oral. This was more or less weekly therapy, 3 weeks out of 4, so you got 3 drugs once a week. And they looked at a dose of 300 of cyclophosphamide and then 400 of cyclophosphamide. And what they found was that 400 was tolerated, a few more side effects, GI, some more cytopenias. They got a high overall response rate in the 70 to 80% range. But they were giving this combination for, honestly, 12 to 13 cycles of therapy. And so one of the questions I raised at the discussion was how these data compared with bortezomib, cyclophosphamide, and dex. And there is no direct comparison trial, but taking some of the data from the IFM study comparing VTD with VCD, looking at the VCD data, with 4 cycles of therapy, there were higher response rates seen than across 12 cycles of the oral proteasome inhibitor. My concern, the concern I raised, was that we might be sacrificing efficacy for convenience by using an all-oral combination. But I have to say, there needs to be a prospective direct comparison trial to confirm that.
You know, I guess I'm biased because one of my patients went on this study. He was an 82-year-old retired radiologist, went into complete remission, and has stayed there now for about 18 months. So I think for some patients, this notion you can give something as a pill rather than injection, less neuropathy than with bortezomib.
I think for some patients,
frail patients who have trouble traveling into New York City and paying for parking, I think there are people who could benefit from this.
I also think that we shouldn't necessarily compare it to the more potent drug, bortezomib. I think really, in reality, the comparison should be to have 2 drugs versus 3 drugs, because if you can only do oral drugs, that's really why you're looking at that, right? I mean, the convenience factor with additive efficacy, that's really what it is. So I think that's an important aspect of looking at that combination.
Just one question we should address for the listening audience. 2 versus 3 drugs in a very elderly patient. I mean, a lot of people might say, geez, lenalidomide dexamethasone is just fine in this population. especially as you point out, because a lot of them are low-risk genetics.
You know, so I just previously mentioned, I think 2 sometimes is fine. We have several ways in which we stratify patients. We talk about the genetics, we talk about fit on fit, but we also are starting to talk more and more about the aggressive relapse or the aggressive new diagnosis versus the more indolent one that you can treat. And I think for this category, you can be a little bit more paused, particularly with the elderly, that if they can tolerate the 2 drug and then you can catch up or arrange in a different way if you don't get the results, I think that's perfectly reasonable.
And do you continue continuous therapy for these patients, or do you stop and start?
The same as for maintenance. I continue on therapy indefinitely.
Everybody using sort of long-term therapy in elderly people? Nobody's stopping and starting? What's the...
Yes, I mean, I think the one thing that we do for older patients, and I mean, I think it's a little bit different than the MD Anderson older patient versus what we see in the community. Because in the community, you're going to see those patients that are 80 plus above. So for those patients that are 80 and above, I think that using lenalidomide dex, I think, is rather appropriate. The key there is actually, in my mind, to start tapering down the dose. And so not to use len dex continuously. So I stop the dex, and we can discuss when you stop the dex. Is it after 12 months or 18 months? I also start tapering back down to len, down from 15 or 25 down to 10 or 15 at 12 months after they've kind of plateaued out. So I think that's the key. When you're going to be using continuous therapy, it's not continuous len dex forever. At some point, you need to taper off the dex completely and just continue on single agent len. And so that's at least what my experience has been. And I think talking about the ixazomib len dex, until we have a good randomized phase 3 study for that in the upfront setting, I think it's difficult to recommend that when we have...
It's going to be paused. If you're adding a 3rd drug, you're going to get longer PFS. But
well, we don't know that for sure, right?
It's likely.
It's likely, but if we look at the relapsed refractory setting and the subset analysis, there's some questions that arise there.
All right. So I think just to recap then, we've sort of concluded there are more patients that need treated earlier a little bit, that we all recommend triplets, we recommend going for complete remission, we like the idea of keeping people on continuous therapy, particularly lenalidomide, but adding proteasome inhibitors if they're high risk, right? It doesn't always work. People relapse, right? Despite our best intentions, most myeloma patients relapse. So let's turn our attention